Well friends, now we'll start discussing further. But before I go further, I would like to tell you few important things about thyroid diseases. So thyroid diseases has a combination of various hypo and hyper. So from these multiple points, we can just get to know what we are going to discuss further. That should not confuse us because the vast array of combination of various diseases. So we can have benign and malignant. We can have same thing presenting as goiter or solitary thyroid nodule, or we can have same combination for hyperthyroidism, hypothyroidism and euthyroid patients. So anything which can be benign can produce solitary nodule or which can be leading to euthyroid or hyperthyroid status. So anything which can be malignant can be presenting as solitary thyroid nodule, can be leading to euthyroid status. So it is a combination of all three things that we are going to discuss now. So this can be a pathological classification, this can be clinical classification, and this can be physiological classification. So from functioning point of view, hyper and hypothyroid are important. From clinical point of view, goiter and solitary thyroid nodule are important. From treatment point of view, benign and malignant are important. So this is how we are going to see further. So we'll start with toxic multinodular goiter. So it occurs in individuals older than 50 years of age who often have a prior history of non-toxic multinodular goiter. So again we came to which is non-toxic, means it does not have hyperthyroidism and it can be having multinodular status. So it is a combination of all this. So when patients prior to this have non-toxic multinodular goiter, they get into hyperthyroidism. So nodules become autonomous to cause hyperthyroidism. So earlier they are non-toxic euthyroid multinodular goiter, but some of the nodules become autonomous. They respond more to TSH stimulation and they start producing more of T4, T3. So they lead to the hyperthyroidism. So the presentation is often insidious in that hyperthyroidism may only become apparent when patients are placed on low doses of thyroid hormone suppression for goiter. Some patients have specific T3 toxicosis. Other patients have hyperthyroidism, atrial fibrillation or congestive heart failure. Hyperthyroidism can also be precipitated by iodine containing drugs such as contrast media or the antiarrhythmic drug called amiodarone. So whenever you get hyperthyroidism after giving iodine containing drugs or iodine, it is called as Jod-Basidoff phenomenon. So it is very important point because Jod-Basidoff phenomenon is seen after you may be given choices, you have to pick up accordingly. We can diagnose toxic multinodular goiter with blood tests which are similar to Graves' disease with a suppressed TSH level and elevated free T4 or T3 levels. Radioactive iodine uptake is also increased. It will show multiple nodules with increased uptake and suppression of remaining gland. Friends, here I would like to clear a difference between hyperthyroidism and thyrotoxicosis. So these two appear synonyms, but they are not though. So thyrotoxicosis is a state of thyroid hormone excess and hyperthyroidism means excessive thyroid function. So by what I mean this is thyrotoxicosis is seen in hyperthyroidism. Both are not synonyms. However, the major cause of thyrotoxicosis are hyperthyroidism caused by Graves' disease and toxic multinodular goiter and toxic adenomas. But here I would like to clear a difference between hyperthyroidism and thyrotoxicosis. So thyrotoxicosis is the state of thyroid hormone excess and hyperthyroidism means excessive thyroid function. So we can have thyrotoxicosis by various conditions which can lead to the increased thyroid function, or thyrotoxicosis can be appearing because of giving of exogenous thyroid hormone. But thyrotoxicosis may not necessarily be rise or secondary to the hyperthyroidism. But whenever there is hyperthyroidism, that definitely means there is thyrotoxicosis. So the reverse is not true in cases of thyrotoxicosis and hyperthyroidism. So please go through, if you are given an MCQ question, which of the following causes are of thyrotoxicosis and which of the following causes hyperthyroidism. So you should go through these terms very carefully. So I will mention few things, like both things are not synonyms. However, the major cause of thyrotoxicosis are hyperthyroidism. So it may be caused by Graves' disease, toxic multinodular goiter and toxic adenomas. So causes of hyperthyroidism leading to thyrotoxicosis are Graves' disease, toxic multinodular goiter and toxic adenomas. But thyrotoxicosis can exist in absence of hyperthyroidism. That is seen in cases where you have exogenous thyroid hormone administration. So it may lead to the thyrotoxicosis but not the excess function of thyroid gland. So this is thyrotoxicosis without hyperthyroidism and thyrotoxicosis with hyperthyroidism. So these two things are different. So how do you treat? Surgical resection is the preferred treatment method for patients with toxic multinodular goiter, with subtotal thyroidectomy being the standard procedure. Whenever you want to perform subtotal thyroidectomy, nowadays Hartley Dunhill procedure is preferred over bilateral subtotal thyroidectomy. So here you may be asked a difference between subtotal thyroidectomy and Hartley Dunhill procedure. What is done in this procedure is one side lobe is totally removed and other side some thyroid parenchyma, like in subtotal thyroidectomy, is left. Here the isthmus and one lobe is completely removed and some parenchyma is left in tracheoesophageal groove. What is the advantage of this? Suppose if you get recurrence of the disease, it may be on the only one side of the trachea. If you want to do total thyroidectomy of subtotal thyroidectomy, then you may not go in both sides of the neck again. So you may just have to restrict to one side of the neck and you can take care of that recurrent disease. Radioiodine therapy is reserved for elderly patients who represent very poor operative risk, provided there is no airway compression from goiter. Next we move on to Plummer's disease, which is also called as toxic adenoma. So hyperthyroidism from single hyperfunctioning nodule typically occurs in younger patients who note recent growth of long-standing nodule along with the symptoms of hyperthyroidism. So here you should notice that it is toxic adenoma. So whenever there is long-standing disease, the nodule is long-standing and patients get symptom of hyperthyroidism. So autonomous thyroid nodules have attained a size of at least 3 cm before hyperthyroidism occurs. So before hyperthyroidism can be apparent, there should be size of at least 3 cm. So radioactive iodine scan will show hot nodule with suppression of rest of the thyroid gland. So it will take the most of the iodine avidly or most of the technetium avidly, and rest of the gland will be suppressed because there won't be any TSH stimulation to absorb radioactive agent in other of the gland. So how do we treat? Smaller nodules may be managed with antithyroid medications and radioactive iodine, but rarely cause hyperthyroidism. Surgery in lobectomy and isthmusectomy is recommended to treat young patients and those with larger nodules. Next we move on to thyroid storm. So thyroid storm is a condition of hyperthyroidism accompanied by fever, central nervous system agitation or depression, along with cardiovascular dysfunction that may be precipitated by infection, surgery or trauma. So please go through all the points. So thyroid storm is precipitated by infection. It may be any viral or bacterial or any of the systemic infection. It may be precipitated after surgery or maybe after trauma. So occasionally thyroid storm may result from amiodarone administration. So it should be managed in ICU. Beta blockers are given to reduce peripheral conversion from T4 to T3. So as you know, T3 is a very active component. So from T4 to T3 conversion, if you reduce it, you reduce the activity of thyroid hormones. So conversion it is reduced by giving beta blockers. Oxygen supplementation and hemodynamic support should be instituted. Glucose iodine or sodium iodate should be given. So sodium iodate can be given intravenously and glucose iodine is given orally. So it should be administered to decrease iodine uptake and thyroid hormone secretion. Excessively large doses of iodide have interesting and complex effect, including an initial increase in organification followed by suppressive effects, which is known as Wolff-Chaikoff effect. So this is very important. You may be asked, Wolff-Chaikoff effect is seen after giving of excessive iodine, and Wolff-Chaikoff effects initially comprises of increase in organification and afterward suppression. So this is called as Wolff-Chaikoff effect. Propylthiouracil therapy will block the formation of new thyroid hormone and reduce peripheral conversion of T4 to T3, and corticosteroids will help to prevent adrenal exhaustion. Corticosteroids also block hepatic thyroid hormone conversion. So friends, after seeing various diseases which will cause hyperthyroidism, now we move on to hypothyroidism. So it is the deficiency in the circulating levels of thyroid hormone that will lead to hypothyroidism and neonates to cretinism. So which is characterized by neurologic impairment and mental retardation. So cretinism is characterized by neurological impairment and mental retardation. Hypothyroidism may also be associated with deafness, which is called as Pendred syndrome. So friends, hypothyroidism can be at various levels. Primary, which is at the thyroid level, secondary, which will be at pituitary level, and tertiary, which will be at hypothalamus level. So we see now causes of primary hypothyroidism. So you get increase in TSH levels in primary hypothyroidism. So what do you mean by that? Whenever there is decreased formation of thyroid hormones by thyroid gland, the blockage to the pituitary is not there. So pituitary will secrete more of the thyroid stimulating hormone. So it is seen in Hashimoto's thyroiditis. So as you know, we have learned earlier that Hashimoto's thyroiditis is the most commonest cause of hypothyroidism. Next, it is radioactive iodine therapy given for Graves' disease, which may lead to the hypothyroidism. Next, we have got the post-thyroidectomy status, which may cause hypothyroidism. Excessive iodine intake can also lead to suppression of thyroid gland and hypothyroidism. Next, we have got subacute thyroiditis. Then medications which are antithyroid drugs or lithium can produce hypothyroidism, which is primary. Rare causes are iodine deficiency and dyshormonogenesis. Next, we have got the secondary causes in which the TSH levels are decreased. We have got pituitary tumor, and pituitary resection or ablation can produce secondary hypothyroidism. Tertiary causes are hypothalamic insufficiency and resistant to thyroid hormone. So clinical features are failure of thyroid gland development or function in utero can lead to the cretinism, and characteristic faces similar to those of children with Down syndrome and dwarfism. Failure to thrive and severe mental retardation are often present. Immediate testing and treatment with thyroid hormone at birth can lessen the neurological and intellectual deficits. So those patients who are identified as cretinism, or they should be prevented to develop cretinism by early identification of these children, and they should be given thyroid supplement. So hypothyroidism developing in childhood or adolescence results in delayed development that may also lead to the abdominal distension, umbilical hernia and rectal prolapse. So whenever you get these three things, you should always rule out childhood hypothyroidism. So patient will be having pot belly along with umbilical hernia and rectal prolapse. So all these three combination will suggest childhood hypothyroidism. So you may be asked a question, the components of childhood hypothyroidism are all of the following except. Patients with severe hypothyroidism or myxedema may develop characteristic facial features as a consequence of deposition of glycosamine glycans in the subcutaneous tissues, leading to facial and periorbital puffiness. The skin may become rough and dry, and it will often develop a yellowish hue from reduced conversion of carotene to vitamin A. So reduced conversion from carotene to vitamin A will lead to the skin problem that is seen in myxedema. Untreated dementia may lead to the myxedema madness. Cardiovascular changes in hypothyroidism include bradycardia, cardiomegaly, pericardial effusion, reduced cardiac output and pulmonary effusions. But cardiac failure is uncommon. So you may be asked a question, cardiac failure is uncommon in or cardiac failure is common in. So you may be given hypothyroidism as a cause. So hypothyroidism is not necessarily seen with cardiac failure. Laboratory findings are seen in the form of low circulating levels of T4 and T3. Raised TSH levels are found in primary thyroid failure, whereas secondary hypothyroidism is characterized by low TSH levels that do not increase following thyrotropin releasing hormone stimulation. Thyroid autoantibodies are present, and highest number in patients with autoimmune disease that were seen earlier, seen in Hashimoto's thyroiditis and Graves' disease, although they are elevated in patients with nodular goiter and thyroid neoplasms. So other findings they include anemia, hypercholesterolemia, and decreased voltage patterns with flattening of the T waves in ECG. There will be, if the patient is too much bad, he may go in coma. With myxedema, they will have hyponatremia and CO2 retention. What is the treatment? Thyroxine is the treatment of choice and is administered in doses varying from 50 to 200 grams per day, depending upon patient size and condition. Starting dosages of 100 gram of thyroxine daily are well tolerated. So friends, after having seen hypothyroidism, now we move on to the thyroiditis. So these two combinations are of hypo and hyperthyroid. They are of functional outcomes. So they have a wide involvement of spectrum. So now we go on to the each of individual disease like thyroiditis, which may be causing hypo or hyperthyroidism. So thyroiditis is defined as an inflammatory disorder of the thyroid gland and is usually classified into acute, subacute and chronic forms. So in acute, we have got acute suppurative thyroiditis. The thyroid gland is inherently resistant to infection as a consequence of its extensive blood supply along with lymphatic supply, higher iodide content and fibrous capsule. So friends, this is very important point. You rarely get infections of thyroid gland because of the following. So here is very important point to remember. You may be asked question. So all these 3 points should be remembered. Iodine, as you know from, it is a good disinfectant used in before surgical preparation. So whenever the tissues which have got high iodine content, they are naturally resistant to infection. So extensive blood supply along with fibrous capsule, these are also contributory factors. But still, though, infectious agents can spread to thyroid via hematogenous or lymphatic route, direct spread from persistent pyriform sinus fistulae or thyroglossal duct cyst. So whenever you get fistulae or thyroglossal duct cyst, they have got communication to the intraoral cavity. So from organisms from oral cavity can spread onto the thyroid parenchyma. Next, we have got penetrating trauma to thyroid gland. So organisms can be directly deposited from external environment to the thyroid. Or thyroid infection can result as a result of immunosuppression. So if the patient's immunity is very low, they may get thyroid infection. What is the treatment? Parenteral antibiotics along with drainage of abscess. Patients with pyriform sinus fistulae, they will require complete resection of the sinus tract along with the area of the thyroid where the tract terminates in order to prevent recurrence. So whole of the tract along with 2 ends should be excised. Next, we move on to the subacute thyroiditis. So subacute thyroiditis can occur in either the painful or painless form. So the spectrum of thyroid disease now goes on to the subacute form. The etiology is not known. Painful thyroiditis is of viral origin or it may result from post-viral inflammatory response. So subacute thyroiditis can be painful or painless. Painful results mostly from the viral origin or the post-viral inflammatory response. So this is very important point. Genetic predisposition may also play a role. Patients will have got sudden or gradual onset of neck pain which may radiate towards mandible or ear. There will be history of preceding upper respiratory tract infection which can often be elicited. So this subacute thyroiditis will have various stages. So we will have initial hyperthyroid phase followed which will be caused by release of thyroid hormone which is followed by a second euthyroid phase when there will be resolution of inflammation which will be followed by euthyroid phase. The third phase of hypothyroidism occurs in approximately 20 to 30 patients. The third phase of hypothyroidism occurs in approximately 20 to 30% of patients and is followed by resolution or return to the euthyroid state in greater than 90% of the patients. So these stages should be remembered which we seen in subacute form of thyroiditis. During the initial phase, there is follicular destruction leading to the increased release of thyroglobulin and thyroid hormones. During this destructive phase, radioactive iodine uptake, that is RAIU, is low or undetectable. After several weeks, the thyroid is depleted of stored thyroid hormones, resulting in a phase of hypothyroidism with decreased T4 and T3 with increased TSH. Radioactive iodine uptake returns to normal or even increase afterwards. Specific treatment is sometimes required in patients with symptoms that will include beta blocker and thyroid hormone replacement. Thyroidectomy or radioactive iodine ablation is only indicated for rare patients with recurrent disabling episodes of thyroiditis. Now we move on to chronic thyroiditis. So the spectrum now moves on to the chronic form. So we have got acute, subacute and chronic thyroiditis. So these all spectrum of thyroiditis, this is very important because various questions can be asked on various form of thyroiditis. The chronic thyroiditis is mostly caused by lymphocytic or also called as Hashimoto's thyroiditis. It is the most common inflammatory disorder of the thyroid and leading to the cause of hypothyroidism. So this is the most common cause of hypothyroidism. We have seen earlier also in primary hypothyroidism, Hashimoto's disease was amongst the topmost causes. Etiopathogenesis. Hashimoto's thyroiditis is an autoimmune process that is thought to be initiated by activation of CD4, that is T helper lymphocytes with specificity for thyroid antigens. Chronic thyroiditis is also associated with increased intake of iodine along with administration of medications such as interferon, lithium and amiodarone. Clinical presentation will be of autoimmune disease. Presenting features, they are more common in women. So male to female ratio is 1:10 to 1:20. So females are most commonly affected. The age is between 30 to 50 years. The most common presentation is that of minimally or moderately enlarged firm gland discovered on routine physical examination. 5% of the patients present with hyperthyroidism, that is called as Hashimotoxicosis. Thyroid-associated ophthalmopathy is rare in patients with chronic autoimmune thyroiditis. So this is one more thing that will be differentiating from Graves' disease. So whenever there is ophthalmopathy, mostly you think of Graves' disease. So thyroid-associated ophthalmopathy is rare in patients with chronic autoimmune thyroiditis. How do you diagnose? An elevated TSH along with reduced T4 and T3 levels. There will be presence of thyroid autoantibodies, that is antibodies against thyroid peroxidase. FNA biopsy is indicated in patients who present with a solitary suspicious nodule or rapidly enlarging goiter. So we will see afterwards management protocols of solitary thyroid nodule. So FNA biopsy is indicated if present with solitary suspicious nodule or rapidly enlarging goiter. Thyroid lymphoma is a rare complication of chronic autoimmune thyroiditis. So it is lymphocyte thyroiditis or it is maybe converting into the lymphoma. The treatment is by thyroid hormone replacement therapy for hypothyroid patients with the goal of maintaining normal TSH levels. The management of patients with subclinical hypothyroidism, that is normal T4 with elevated TSH, is controversial. Treatment is generally recommended for male patients and those with TSH greater than 10 milliunits per liter. So this is very important point. The treatment is treatment is directed towards maintaining of normal TSH levels. So treatment is also indicated in euthyroid patients to shrink large goiters. So you give thyroid supplement, the TSH levels will go down. TSH will cause generally more of the thyroid parenchymal enlargement. So when you suppress TSH by giving exogenous thyroid hormone, the parenchyma will shrink. So this will cause in shrinkage of goiters. Surgery may occasionally be indicated for suspicion of malignancy or for goiters causing compressive symptoms or cosmetic deformity. So friends, having seen all these diseases, now we move on to Riddle's thyroiditis. So it is also called as Riddle's tumor or invasive fibrous thyroiditis. It is characterized by replacement of all or part of thyroid parenchyma by fibrous tissue, which will also invade in adjacent parenchyma. So you have got thyroid fibrosis which will be invading in another neck structures. So etiology of disease is not clear. So this is very interesting disease. It has been reported to occur in patients other than autoimmune disease such as pernicious anemia. It has been reported to occur in patients with other autoimmune disease such as pernicious anemia and Graves' disease. So whenever you got other autoimmune disease, the thyroid gland may also be affected by fibrous infiltration. So this association coupled with the presence of lymphoid infiltration and response to steroid therapy will suggest primary autoimmune etiology. So thyroid fibrosis that may be responding to steroid therapy, you should suggest Riddle's thyroiditis. Riddle's thyroiditis is also associated with other focal sclerosing syndromes such as mediastinal, retroperitoneal or periorbital or retroorbital fibrosis. So whenever you have got fibrosis in other parts of the body, presenting with different symptoms, you should look for reduced thyroiditis. Patients may have got sclerosing cholangitis, suggesting that it may be a primary fibrotic disorder. So sclerosing cholangitis that we have seen earlier in gastrointestinal tract in hepatobiliary tree, the same disease can be presenting as reduced thyroiditis. So patients may be presenting with symptoms of hypothyroidism and hypoparathyroidism as the gland is replaced by fibrous tissue. So this is the disease which will be presenting as hypothyroidism. So along with the hypothyroidism, there will be hypoparathyroidism because the blood supply to the parathyroids will also be affected because of entrapment of blood vessels in the fibrous tissue. The diagnosis needs to be confirmed by open thyroid biopsy because firm and fibrous nature of the gland renders FNA biopsy inadequate or inconclusive. You won't get the cells even if you put the needle because there will be a lot of fibrosis. Physical examination will reveal a hard and woody thyroid gland with fixation to surrounding structures. Surgery is mainstay of treatment. Chief goal of operation is to decompress the trachea by wedge excision of the thyroid isthmus and to make the tissue diagnosis. So you have to release the pressure on the trachea by wedge excision of the isthmus. So in reduced thyroiditis, the treatment of choice or surgery of choice is wedge excision of isthmus. You may be asked question, you should not venture in other parts of the thyroid because you may be damaging other structures because they have entrapped in the thyroid loops. For patients who may be relapsing, they may be better put on steroids or tamoxifen. So friends, having gone through various types of hypothyroid and thyroiditis status, we have seen various types of conditions which will produce hyperthyroidism, hypothyroidism in cases of various forms of thyroiditis.